Hi, my name is Paula Briggs and welcome to the Paula Briggs podcast. The podcasts are designed to update your knowledge of gynecology, common conditions presenting to primary care. Today's episode is on heavy menstrual bleeding. What I hope to share with you is what questions to ask, what investigations are necessary, and how to treat women who have heavy menstrual bleeding. If you have any questions, you can email us at thepaulabriggspodcast@gmail.com, or you can find us on Twitter. In this podcast, we're going to talk about heavy menstrual bleeding, heavy periods. The terminology menorrhagia really has been put to bed, and it's far better to use terminology which women can understand. So this is simple guidance for managing a common problem in primary care, which is possible for most women, and that means that they're not inconvenienced by referral to hospital and often more than one trip to hospital. So we're going to cover what is it, what causes it, and what treatment options are there for women. This is a very common problem. Although 1 in 20 women between the ages of 30 and 49 will consult their GP, in fact, 20% of women have a problem, and they're not necessarily going to talk about it unless you ask specifically. So 1 in 5 women affected by heavy menstrual bleeding. It's the commonest reason for secondary care gynecology referrals. And as we go through this presentation, there will be situations where women need further investigation, and that may require referral to secondary care. But I think the most important message here is that most women can be very well managed in a primary care setting. And there was a very large audit done looking at hysterectomy rates and pathology associated with those hysterectomies, and most of them were for benign reasons, completely normal uteri removed, when women could have had other treatment options. So NICE guidance has been updated. The initial guideline was NICE guideline 44 and it's now 88, and that makes it clear that women should be offered treatment following the recommendations from NICE, and therefore it's inappropriate to offer hysterectomy as a first-line treatment, and that happened reasonably commonly in the past. There are many potential causes of heavy bleeding. The most common cause is known as dysfunctional bleeding, and that's due to the influence of hormones, which we've talked about, which we will talk about in some of the podcasts to come. Heavy bleeding becomes common in the run-up to the menopause, and that's because women have their ovaries stimulated by follicle-stimulating hormone. Estrogen is released from the primordial follicles as they're stimulated, but the levels don't reach the point that triggers the LH surge or the LH peak, and ovulation doesn't occur. So essentially you have unopposed estrogen, which causes the lining of the womb to thicken, and it then sheds chaotically. And that's the same thing that happens at menarche and also in women who have polycystic ovary syndrome. And again, we will cover PCOS in a separate podcast. In a smaller number of women, there will be pathology to account for bleeding, such as fibroids or polyps, and both of these things will increase the surface area from which women bleed. And we all worry about missing cancer, but in fact, it is way down the list of the likely diagnosis. But it's really, really important to have this in your mind because it's becoming commoner, and there are certain risk factors which we will look at later in this podcast. Bleeding may be associated with use of copper intrauterine devices. They can cause inflammation and they certainly don't improve bleeding. Medical disorders such as underactive thyroid or rarely von Willebrand's disease can be associated with heavy bleeding. And An awful lot of information can be gathered from the history. So if you have a patient who describes excessive bleeding at the time of colposcopy or tonsillectomy, then have a high index of suspicion about von Willebrand's disease, and you can check for the factor. But if somebody hasn't experienced that, then this is a rare cause of heavy periods, and these would be periods that had been heavy lifelong. So the important thing from this slide is to be very clear that for the vast majority of women, you are not going to find a pathological, anatomically pathological reason for her having heavy bleeding. And the one test that often isn't done in primary care and should be done is a full blood count. What happens in women with heavy bleeding is that it's a very gradual process. So women accommodate for having a low hemoglobin. If they end up with a hemoglobin of 6 and have a very heavy bleed, then obviously that can be potentially very dangerous for them. So full blood count's important. Thyroid function tests may be appropriate, but not always, and that will depend on the patient's history. So this is a really useful way of having in your mind what might be causing heavy periods. It comes from FIGO, that's the Federation of Gynecology and Obstetrics Working Group on Menstrual Disorders, and it's called the PAM-Cohen classification system. So on the left of the screen, you see potential structural causes of heavy bleeding. PAM is P for polyps, A for adenomyosis, which is bits of the lining of the womb embedded in the muscle, making the uterus bulkier, and again, making the surface area from which women bleed larger, the endometrium. Leiomyomas are fibroids, and we're going to look at what type of fibroids cause problems in the next slide. And then malignancy, which is predated by hyperplasia in most cases. So those are the structural causes, and then the non-structural causes. You have coagulopathy, so bleeding disorders, ovulatory dysfunction, the commonest cause of heavy menstrual bleeding, endometrial causes. So that might be inflammation, iatrogenic, that could be insertion of a copper IUD, and then not yet specified. So I think I'm a visual learner. I think it's very easy to have that in your head and to have it in the background when you're taking the history from the patient, which is the most important thing. So fibroids can be either subserous, that means they're on the outside of the uterus, intramural, which is in the muscle, or submucosal. And it's the submucosal fibroids which cause the problems. A type 0 is a fibroid polyp, and that will most often need to be removed, and that can be done hysteroscopically using a morcellator. What you see here is a type 1 where most of the fibroid is within the endometrial cavity, and a type 2 where most of the fibroid is within the myometrium. And then you've got type 3 and 4. Now, most of the time they won't cause problems at all, unless they're multiple, which will again make the uterus bulky and make the endometrial surface area greater. And then for heavy menstrual bleeding, type 5, 6 and 7 are largely irrelevant. The relevance of large subserous fibroids for women is that they can cause pressure, they can cause urinary frequency, but they don't cause heavy menstrual bleeding. So it's important that you understand the type of fibroid, because a type 1 or a type 0 fibroid might be very small, but it still causes significant problems. The help group is a very useful resource. I have a link at the end of this presentation. There are sections for healthcare professionals which talk about causes, investigations, and treatments for heavy menstrual bleeding. So if we just run through this pathway, a patient comes feeling tired all the time. It's a very common presentation in primary care. So take the opportunity to ask about heavy bleeding, bearing in mind what was said at the beginning, that 20% of women have heavy periods, but only 5% will go proactively to their GP or any primary care healthcare professionals. So it's important to ask, are your periods heavy? Well, actually, your patient may have nothing to benchmark what she gets against anybody else. So I'm going to show you in a couple of slides something that might be useful. In the past, we used to determine whether bleeding was heavy or not based on the volume, but actually the initial NICE guideline made it clear that if a patient thinks her periods are heavy, then they're heavy. And based on your history, if you think her periods are heavy, then of course carry out a bimanual examination. As I said before, do a full blood count, think about other risk factors, particularly thinking about coagulation defects. And if there's no suspected organic pathology, then you can start pharmaceutical treatment following the recommendations produced by NICE, which we're going to talk about a little bit later. If the first treatment fails, try a second. You can add treatments together. If that doesn't improve the problem, then further investigations are recommended. That might be ultrasound, it could be hysteroscopy, more blood tests potentially. And only really if significant pathology is detected would that patient need to be referred on to secondary care for further assessment. So what's important to consider in the history? How often does she bleed? How much does she think she bleeds? And that can be assessed by asking about the number of pads she uses, what type of pad she uses. Does she use tampons and pads? Does she flood? A change in bleeding pattern is particularly important. So if somebody's had manageable periods all their life and suddenly they become heavy, that's relevant. Or if they start bleeding in an irregular manner or between periods, that would be a red flag sign. I've already said impact is very important. So even if for one woman the bleeding wouldn't be a problem, if for another it is, then it's a problem. This is a menstrual pictogram which was developed for research purposes, but actually it's a useful visual aid. You can get that from the internet. You can use it from the resource in the podcast series, but it might give you an idea of what kind of bleeding your patient's talking about. Which investigation is undertaken first line depends on the individual patient and the information gained from the history and the examination. If you feel that there is a high risk of endometrial pathology, either polyps or submucous fibroids, then hysteroscopy is the better first line investigation. If not, then ultrasound has an awful lot to offer. And personally, I feel as a clinician using ultrasound, it is a dynamic process. So I think obviously most GPs don't perform ultrasound, so you would be required to send the patient for an ultrasound scan and to interpret the report. And that's certainly better than nothing, but it's not as good as doing the procedure and then basing your treatment on what you find. And you can use either saline or Instilagel as a negative contrast with ultrasound to gain very similar to what you would with hysteroscopy. However, if a patient has polyps and she's going to have these removed hysteroscopically, and that can be done in one setting with minimal disruption to the patient, then hysteroscopy is the better first line investigation, and that tissue then is sent for histological examination, and a small number of polyps will have malignancy associated with them. So back to malignancy. As I said before, this is something which we need to be very careful not to miss. Most women are post-menopause, but not all. So if you have a woman who is premenopausal with a change in bleeding pattern, then it's really important to refer her on a 2-week rule if you're concerned, rather than to sit on her. So, although I'm saying the vast majority of cases can be managed in primary care, just be cautious. Hyperplasia is a risk factor. There are now guidelines about hyperplasia with and without atypia. Without atypia can be managed using Mirena, but that should be done in a secondary care setting. So risk factors for endometrial cancer include nulliparity, polycystic ovarian syndrome, because those women have long periods of unopposed estrogen, obesity, again, adipose tissue will release estrogens, impaired glucose tolerance, because those women, they will tend to be overweight. Ovarian tumours can release hormones which cause the endometrium to proliferate. And then there are women with Lynch syndrome. And actually, I saw a woman who had endometrial cancer in her early 40s with Lynch syndrome yesterday. And, you know, these are rare, but just have it at the back of your mind. So when to investigate further or refer: age over 45, endometrial risk factors, as you saw on the previous slide, other symptoms and signs, that could be pain. You can have degeneration of fibroids causing pain, abnormal ultrasound findings, or failure of treatment. And not all women over the age of 45 would need further referral, but in a secondary care setting, an endometrial sample can be done under hysteroscopic guidance, and that is the current recommendation. Blind endometrial sampling is no longer thought to be appropriate. Back to what I said about most women being able to be managed in primary care, the vast majority of the patients who present with heavy periods are going to be under the age of 45. You'll be relieved to hear that I'm not going to go through this algorithm in detail. It'll be there as a resource for you to go back to after the podcast. So these are the treatment recommendations from NICE. First line treatment is a levonorgestrel releasing intrauterine system. For women over the age of 45, my preference is Mirena, because it also has a license for endometrial protection as a part of HRT, but we now also have Levocert, which is a branded intrauterine system with the same amount of levonorgestrel as Mirena, 52 milligrams in the core. So not all women want Mirena, not all women can find someone to fit a Mirena. Bayer have a training program whereby they will send specialist nurses who are registered trainers into primary care setting to train GPs and practice nurses. And I think I've always thought we need more IUC, intrauterine contraception fitters, and it's important that we can use to remember that we can use contraception for its non-contraceptive benefits to manage common gynecological problems, and I think that has the potential to make a difference for management within GP. Second line treatment options include tranexamic acid. You need to use a high enough dose to achieve the desired effect, and that is 1 gram 4 times a day for up to 4 days or longer. 4 days is what you see in the BNF. That can be used either alone or in combination with non-steroidal anti-inflammatory drugs. They inhibit prostaglandins. It doesn't matter which one you use, but ideally they would be used for women who have pain as well as heavy bleeding, and ideally started before the period starts, and that can be difficult to predict. Then there's the option of combined oral contraceptive pills or progestogen-only pills. So I think in association with lots of other people, that Mirena had a huge impact on how we manage gynecology patients, and also desogestrel progestogen-only pills, because if women take these long term, and we're talking really 11 to 13 months, then the vast majority will become amenorrheic. Third line includes norethisterone. I never use norethisterone day 5 to 26. I don't really know what the logic for that would have been. Norethisterone is a very useful drug. It can be used every 5 milligrams 4 hourly in women who are bleeding heavily until they stop, and then taken 3 times a day until you can make arrangements for further investigation or a definitive treatment option like inserting an intrauterine system. It is similar, it has a similar impact on VTE risk as a 20 microgram pill. So I'd be wary in women who have risk factors, including a body mass index. Certainly over 40, I would be anxious. Provera is another option, which does not carry the risk of VTE, but it's not quite as effective at stopping bleeding. And you might need 20 milligrams 3 times a day in someone who is bleeding heavily. So these are often doses outside of the product license. Mirena, so as I said, revolutionised gynecological care. You are basically delivering the treatment to where the problem is. So instead of a woman swallowing a drug, having to absorb it and then it making its way to where the problem is, this drug goes directly to the problem. And the concentration of levonorgestrel within the endometrial cavity is very intense, prevents endometrial hyperplasia, keeps the endometrium thin in most women. It's fit and forget, lasts for 5 years or longer. 5 years is the license for contraception in women under the age of 45. Over the age of 45, Mirena can remain in situ for up to 7 years or longer as long as the woman remains amenorrheic. For endometrial protection as part of HRT, the license is 4 years, but we leave it 5, but no longer. So those are, a little bit variable licensed indications, which sometimes people find confusing. So, Mirena is the first line recommended treatment. As I said, not all women want it and not all women are eligible. So you might have a woman who's got a large fundal septum. That increases the risk of expulsion. A woman with a submucous fibroid may not retain Mirena, or a woman with a very large cavity. So the nice recommendation is that you can insert up to a cavity length of 12 centimetres. But if you consider that most women have a cavity length of 7 to 8 centimetres, well, in a woman with a 12 centimetre cavity, she's going to be shedding from a larger surface area. So a Mirena is less likely to be effective, but sometimes it is. What happens once it's inserted, there is bleeding, which is not a side effect, it's a process. So under the influence of the intense hormone, the woman will start to shed her endometrium, and that will continue for 6 to 12 weeks. I think it's really important that women are advised of that, because otherwise they think, oh my God, I started with heavy bleeding and now I'm bleeding every single day. This is worse than what I had at the beginning. But if they expect it and they know it's going to go away, then most women will be patient with that. I think it's a lot to ask women to wait 6 cycles. I think if somebody's still bleeding all the time after 12 weeks, then as long as the Mirena is in the right place, you can add in some other treatments. You might add in a combined pill or just estrogen alone. That will sensitize the progesterone receptors within the endometrial cavity. So you might add 1 milligram of Sandrina just until she becomes amenorrheic. But it is important to be sure that the Mirena is in the right place. So risks associated with any intrauterine contraception insertion are infection, that's a low risk, expulsion. The rate quoted is 1 in 20, and I don't think I've seen that level of expulsion, and perforation, which is a rare complication, 2 in 1,000. Waiting for the next slide. So this just shows you that with a combined pill, you get about a 40% reduction in bleeding, roughly. With Mirena, roughly an 88%, 90%, I usually say, it's easier, reduction in bleeding. Clara is quite a unique combined pill with an additional license to manage heavy menstrual bleeding in women who require contraception and who have no structural abnormality. And the reduction in bleeding with Clara is very similar to what you get with Mirena. So it's a significant improvement on other pills. And it's a great option for women who have no contraindications to combined hormonal contraception, i.e. no migraine with aura, no family history of VTE, and a first degree relative under the age of 45, not overweight and no hypertension. But it can be a useful option for women who don't want or can't have Mirena for whatever reason. So this is just a summary of what I've covered in the podcast today. Heavy menstrual bleeding is common. Certainly a good history can be taken in primary care. Most women can be managed in primary care, reducing unnecessary referral and cost associated with secondary care referral. There are very clear recommendations from NICE about treatment options. Endometrial ablation is obviously a more invasive procedure offered in secondary care, and it's great. It gets rid of the endometrium in most women. What's potentially problematic with that is women who then develop bleeding can be very difficult to investigate, so it can be difficult to use ultrasound and hysteroscopy, and some of those women will have to have a hysterectomy, although they may have no significant underlying pathology. So again, a final word is that hysterectomy is not first-line treatment for heavy bleeding. It used to be that everybody had a member of the family who'd had a hysterectomy, and that has changed, and changed for the better. So I hope you enjoyed this first podcast, and I hope you'll come back for more. We will be posting once a week to try to support you in primary care to manage your patients with gynecological problems. And if you want the more comprehensive package, then that's going to be available from Patreon, and you can access the information at Paula Podcast.